Hi everyone, welcome to Migraine New Zealand. Today we are talking with Dr. Pyari Bose from Auckland, and he's a neurologist, and I'm going to hand it over to you and let you continue, tell us a bit about who you are, what you do, and go from there.
Hi, thanks, Briar, for that introduction. So yes, I'm Pyari Bose. I'm a neurologist. I trained in the UK and I moved to New Zealand about a couple of years ago. I've got a specialist interest in headache, and I guess that's the reason why I'm going to be talking about headache today. Um, so when I did my doctorate, my research was into migraine, where I was scanning people during different phases of a migraine attack to try and understand what was happening in people's brain, with the hope that eventually that knowledge would let us open the doors for better treatment, because there is a huge problem. There is a lot of people out there who have tried the existing medications that we have, and then they are stuck. So yeah, I would like to talk about, the extent of the problem. I would like to maybe just touch upon a big problem in Auckland that I've found, which is post-traumatic headache. And also I wanted to just talk briefly about medication overuse.
Absolutely. Go right ahead.
So migraine is the second most disabling condition worldwide. So several studies have pointed towards it, and it's a common problem. It's about 12% of the world has migraine. So you look into a room of 10 people, there will be somebody in that room with migraine. It is really common, and it is quite disabling as well. So if you look at studies worldwide, a lot of people miss out on their social life, miss out on work, and because of that, miss out on, finances and all these consequences. It's extremely disabling. We haven't got studies into costs in New Zealand, but if you look worldwide, I mean, economies lose millions of dollars, whether you look into sickness or cost of hospital treatment. So it's a huge problem. I did look into some data with migraine admissions in hospitals in New Zealand. And again, it's a big problem here, just like it's similar to data that we see around the world. So in New Zealand, I guess when it comes to treatment, you have the conservative treatment, or kind of like non-drug related treatment. I'll talk about things that have evidence. I'm not going to talk about things that don't have evidence.
Yeah, no.
Yeah. And I'll talk about drugs that can be used. And in drugs, you have something that you can take for acute treatment. That means when you actually have a migraine attack, what to take. And then I'll briefly touch upon things that can be used for prevention. So conservative, if people are looking for things that are not drugs, essentially, there is some evidence for vitamin B2 or riboflavin. So this is something that you can buy over the counter and try. There is some evidence for this. The other thing is magnesium supplements. So if someone was looking for non-drug related thing, that is another option to consider. Amongst different types of exercises, people sometimes ask me if there is any particular exercise that is good for migraine. And there was a study that came out a couple of years ago where people tried yoga, and it found almost similar effects as medications.
Wow.
But most of these studies have been quite small, so you need to have like bigger studies to be sure that that effect, you can kind of continue that in a larger population as well.
With the magnesium, just to interrupt you, the magnesium and the riboflavin B2, how much should you be looking at taking daily for that?
So that's, you're looking at about 400 milligrams, so yeah, but I guess the problem is
separate throughout the day. Like what was the research, or what do you know that is best to be taken and how?
Yeah, I mean, just once daily, total. I guess with magnesium supplements, the problem if you overdid it is that people can get abdominal cramps and diarrhea and things like that. It's not so much of an issue with vitamin B2.
Mm-hmm.
So, that's
Awesome.
what
That's
the
cool.
studies here. And when it comes to medication that you can take when you actually have a migraine attack, so usually we start like this, like you try paracetamol first, ibuprofen next, and you can take the combination of paracetamol and ibuprofen. And if that doesn't help, then there is a migraine specific medication. The group is called triptans, and in New Zealand you have 3 which are currently available. So sumatriptan oral, sumatriptan injections, and rizatriptan oral. And out of these 3, I have to say the best evidence is for sumatriptan injections.
Wow.
So when you look at different drugs and compare the effect, one of the things that you look at is the numbers needed to treat. So how many people must you treat before you notice a benefit? And the number is lowest with sumatriptan injections. It's like 2.3 or something like that. So yeah, that's the best evidence.
And obviously with the injections, how do you go about getting them? Is that like a normal prescription from your GP, or do you, how do you get them?
GPs can prescribe it. It's quite easy. There are a lot of YouTube videos on how to do it. So it's just a cartridge, a couple of cartridge comes in a box, and then there's a device that looks like a pen. You load the cartridge, and then just like a pen, just click it, and that's done. You can click it on your arm, your leg, and it's very quick acting.
Wow.
With triptans, the potential side effect is drowsiness. That's the major side effect with triptans. Some people can get a bit of chest tightness, throat tightness. And if someone has a history of heart disease, like has had a heart attack before, I would not recommend using triptans because that could aggravate the heart condition. So that's for, acute treatment. And then you come into the realm of preventive medications. There are quite a few in that. So
and not as many in New Zealand.
Yeah.
There's more preventatives worldwide than there is in what there is in New Zealand.
Yeah. You got a point there, Briar. So what we have in New Zealand, so amitriptyline, nortriptyline, propranolol, topiramate, and candesartan. Now, I would like to make a point here. All these medications, they were initially designed for something else, and then people with migraine who were taking those medications found that they were useful. So then they did separate research trials, including patients with migraine, and putting them on these medications, and they were found to be effective. But the thing is, they were not designed for migraine. No one knows actually how these medications work, So now coming back to worldwide. So what has been designed specifically for migraine? So in the 80s, there were some research studies, both in humans and animals, which showed that a chemical called CGRP goes up in the blood when people have migraine attacks. And now we have a drug that targets CGRP. So it's called CGRP monoclonal antibodies. It's not available through Pharmac. I mean, it is possible to get it through a prescription. But that's something potentially that will be something up and coming. And they have a tablet form of it as well. So there is a CGRP antagonist, so one called rimegepant. And interestingly, this is some really fantastic news for migraine, people living with migraine. Rimegepant has been approved for both prevention and acute treatment.
Yes.
There is no, no medication that does both, and this one, it does both. So hopefully, I have been, as soon as the news came out, I've been like emailing that company like relentlessly, like we need it,
We do.
Yeah. So they have been, they have been positive, and they are trying to launch it in Australia and New Zealand. Don't know when that would be, but at least, it's coming.
It'll
And
come, and then Pharmac will not fund it.
so, yeah. So you've raised an interesting point, Briar. I think there needs to be a good patient, patient pressure group. Otherwise nothing's going to change, because
Absolutely.
I mean, there are so many neurological disorders like, stroke, Parkinson's disease, migraine. If you look at that, the biggest bulk is migraine. I mean, that is the biggest bulk. But when you look at funding, I mean, it's very different. I mean, migraine probably gets less funding compared to other specialties. I'm not saying that, you should not fund other specialties. That's not what
But
I'm saying.
include migraine in that funding.
That's right. Yeah, yeah. If
Yeah.
if you don't look after the biggest chunk of the problem, the patients with the biggest chunk of the problem, then it's not a equitable distribution of resources. And that's a problem. And I think charity groups will have a vital role to play, in this. And I think we have to make people more aware. How disabling it is, the lack of funding, the lack of resources. I think it's a huge problem.
Absolutely.
Yeah. I mean,
That is our next plan for Migraine New
yeah.
Zealand after
Yes.
Migraine Awareness Month, and we've had a bit of a break. Our next plan is to head for Pharmac and get some funding for CGRPs in New Zealand.
Yeah. Yeah. So, the oral medications will come at some point. I do not know the cost of them. The company's not released that information yet, but hopefully it'll be cheaper than the injections. Usually injections tend to be a bit more costly compared to tablets. I mean, then you have like third line options. So when people don't respond to the acute medication, they don't respond to the preventive medication, what else can you do? So you can do something called a greater occipital nerve block, which is like a single injection of steroids given to the back of the head. The success rate with that is 30 to 40%. It's not a guaranteed success. Other options include Botox for chronic migraine. So you were asking me about hospitals. So
there's been a lot of talk on the Migraine New Zealand chat group in regards to what if preventatives and things, if they're in an attack and triptans aren't working, acute medications not working, what's best going forward, and how do we approach A&Es and hospitals and things like that to get the right medication for them?
Yeah. There are a few things that I want to talk about in relation to that. One thing is, it is important to address medication overuse. So whether it is triptans, whether it is paracetamol, whether it is codeine, if someone takes that on a daily basis, hoping that that will kind of prevent the migraine attacks, they get into this vicious loop where they have like a chronic background headache that will never go. The problem is, when it comes to that, you can prescribe whatever you want, whatever preventive that you want. It's not going to work if you're overusing medication, because medication overuse, that's a separate thing to address. I've seen patients who take any of these medications on a daily basis. Once they come off the medications, 2 to 3 weeks later, things might settle down. Worst case scenarios, we've had to admit people into hospital to detox them from their overused medication. So I think that's
what are people best to do when they've what are the signs of medication overuse apart from the daily headache, I guess, or the daily thing, but what are also people meant to do when you're not meant to be taking triptans for that period? What do you suggest?
Yeah, I guess for triptans, I would say to use it maybe 10 days or less in a month. And on top of that, if you wanted to take Panadol or ibuprofen, that's fine. But if you took triptans like 20 days in a month, then it just becomes harder to treat the headache. And the other thing is anything that's an opiate. So when I say that, I mean things like codeine, tramadol, and dihydrocodeine, morphine, all these things. These should not be used for headaches.
Yeah.
Sometimes what happens is, I guess when people go to an ED department, their priority is to get people out, so take the pain away quickly and out of ED, because, their priorities are different,
Yeah.
it's, but then what happens is sometimes, people get hooked onto those medications, and then it becomes quite challenging to manage them in an outpatient setting. And also, I mean, for patients themselves to carry on in their lives, they want to be headache free. So I would say not to use any opiate based medication for the control of migraine. The other reason being that studies have shown that people with migraine, they have dysfunctional opioid receptors in their brain. I mean, that's just a fact. So they get hooked onto opiates pretty quickly. So that's another reason why not to prescribe opiates for people with.
So what would you say? I believe I saw something the other day about like the normal Panadol brand had codeine in it, I want to say. What are your thoughts on that? Is that a yes, a no?
No,
No,
no.
no,
If the Panadol contains codeine, no, don't.
no. Yeah, okay.
Yeah,
Just
that's out.
no.
Yeah, yeah, yeah.
Okay.
So yeah, yeah. If you take Panadol, that's fine as long as you limit it to less than 15 days in a month for Panadol. So each of these numbers, these medications, sorry, have got a number of days that you're allowed to take them per month. So for triptans, it's 10 days. For Panadol, ibuprofen, it's 15 days. If you start taking more than that, then you start getting like a daily headache. So that's
And
something that.
yeah, and so then if you're in that stage of the daily headache, what are you best to do if you can't take medication? Live
Well,
with it or
yeah. So then we are going into the realm of preventive medications. So yeah, if your headaches start creeping up and it's 15 days or more per month, then you need something to bring that frequency down, because you need to function. Can't function with 15 or more days of headaches per month. So again, with the preventive medication, there are quite a few, and it's very difficult to kind of predict in advance which one a person would respond to. So most of the time it's just trial and error to find out what works best. So there might be reasons why you would choose certain ones over the other. Like, for example, someone with a history of asthma, I would not use propranolol because that would potentially worsen the asthma. Someone with a history of depression, I would not use this medication called topiramate because sometimes that can aggravate it. Someone who has a history of high blood pressure and they have migraine, I would choose candesartan because it's a blood pressure medication and it has been found to be useful for migraine as well. Again, someone who has concomitant like anxiety and things, then amitriptyline or nortriptyline might be a better option. So that's the way that I would choose the preventives. And again, with the preventives, the other thing to note is that many times people would start at a low dose and then quit it, saying that it's not working. The problem is, there is an optimum dose for everyone and it's different for everyone. So you have to at least reach that optimum dose and then look if it is working or not before quitting. Because amitriptyline, many times people try 10 milligrams and then they come off it, but people may need 30 milligrams or 40 milligrams to show effect. Of course, if they get side effects at the lowest dose, then that's a no. We have to think of other alternatives. Yeah.
Absolutely. Yeah. Wow. There's a lot there I was ticking off in my head going, oh, shouldn't have been put on that one, shouldn't have been put on that one. But hey, I'm off them now, so all right, we live and we learn. Yeah, absolutely.
Yeah.
Cool. So that's kind of covered, I guess, medication overuse, headache, and what you've got to say.
Yeah. I mean, I wanted to briefly talk about post-traumatic headache as well. So if you look at worldwide data, head injuries, or concussion, in other words, the number is about 100 per 100,000 population. In Auckland, it's about 700 per 100,000 population. It's a huge problem. And it could be because of variety of factors, like, because, people love rugby here. And then motor vehicle accidents, Auckland traffic is just getting worse and worse, and unfortunately, a lot of domestic violence incidents as well. So it is a big problem here. And when it comes to post-traumatic headache, unfortunately, not enough research has gone into it. And how we normally treat it is we ask questions to find the headache phenotype. So if the phenotype is fitting with migraine, we treat it with migraine medication. If it fits with tension type headache, we treat it with tension type headache medication. So when someone has a post-traumatic headache that looks like migraine, it's not saying that they have migraine, because it was the trauma that led to that. Whereas with migraine, like proper migraine, you don't have a history of trauma. So I guess it's a huge problem. And one thing that happens commonly is, again, people get prescribed, codeine, because in the acute setting, you do want to get the pain off, but maybe after a month after the injury, they need to come off the codeine or tramadol, because otherwise they will just get used to that and hooked onto that, and it becomes a problem.
Yeah, absolutely. And so obviously, you see a lot of people with migraine what is it? PTS? No? Is it PTD? No. I don't even know what I'm talking about. And what would you do if it wasn't the migraine type of medication? Is it the same sort of thing for the tension headaches, or is it different medication for that?
Yeah, tension type headache is different. For tension type headache, so interestingly, tension type headache is very common. It's thought to be less disabling than migraines, but because it is less disabling, not enough research has gone into it. So the choices that you have for tension type headache is limited. So you start with things like ibuprofen. If that doesn't work, then amitriptyline. Then there have been some small studies where they've used drugs like gabapentin, topiramate, and even few small studies using Botox in tension type headache. But you're kind of stuck for what to do with in terms of drugs, because not that much research has gone into tension type headache.
Okay. So, yeah, there's lots of research that still needs to be done, and New Zealand needs to up their game with the medications that are available here in New Zealand as well. Absolutely.
Yeah, I guess lot of it's exciting times in terms of migraine medications. A lot of new discoveries happening all the time. A lot of new drugs coming, and we need to try our best. I guess. As doctors, we do try our best, but it would be good to have patients to come together on this one as well. And we do try to get these medications come across. So I'll just talk briefly about things that are happening worldwide.
Absolutely.
There are things like CGRP, monoclonal antibodies. There are 4 different ones. Potentially one, we can get it in New Zealand, but it's not pharmac funded. So that is Aimovig or Erenumab. Then Rimegepant is an oral CGRP antagonist that is it just been FDA approved. So hopefully sometime in the future we'll get it over here. And then there are some implants. We call it like neuromodulation. So these are devices that can be used to treat migraine. Now, I had good experience using a device called transcranial magnetic stimulation. So it's a handheld device. It's just about that big that you place at the back of the head, and it sends a magnetic impulse. Now, the advantage with that device was it had no drug-related side effects. Either it worked or didn't work. It was fantastic. But unfortunately it became a victim of COVID. The business went bust. So I was in the process of trying to get it. One of my colleagues in Palmerston North was trying to get it as well, but
Mm-hmm.
that company's gone bust. Then in Israel, they have come with another neuromodulation device, which is actually stuck on the forehead, and you can it sends out an electrical impulse, and you can control that with your mobile phone. So again, we don't know what the cost of that is, but I have been trying to. I've been talking to the company to try and get that here. We'll see what happens. And yeah, so these are the things. There is one drug called lasmiditan, which is available in Europe and the US. Hopefully that will come to us at some point. So there are things that are happening, and some things that we can look forward to that will be launched in New Zealand.
Absolutely, absolutely. And yes, I have seen a lot of, obviously it is Migraine Awareness Month currently worldwide at the moment, and I know that America are doing a lot of stuff on the new era of medications and things like that, and there's been a lot of talk about the neurotransmitter devices and things like that, and there's been a lot of more coming to the market and things like that. And I have myself been in touch with a few companies, and they're like, yeah, at the moment there's nothing. At the moment there's nothing, but we'll look. But yeah, it really is about trying to get them to be aware. And there really is nothing down here with significant studies and research into the actual devices and things like that. So there definitely is things that we can look forward to here in New Zealand for migraine treatment and things like that. Absolutely.
Yeah. I mean, so when I was in the UK, I used to work with a charity called the Migraine Trust. And so one of the things that they used to do was like the members would offer to volunteer for research studies. And, I guess that's something that we can look into in New Zealand. So that will enable like some of these companies to come and invest in New Zealand, because that we do need that. We do need more treatment options, because we don't have we don't have
our few seven our seven of both preventatives and triptans are not enough. Yeah, absolutely.
Yeah.
Awesome. Well, yeah, is there anything else that you wanted to add?
So one drug that I didn't touch upon is something called dihydroergotamine. Now it's very important that people are assessed for their headaches and a proper diagnosis is made. We need to know, because like for example, people may have symptoms that look like migraine, but it may be something completely different, and the treatment might be very different. So for example, meningitis and encephalitis can mimic migraine. They can have headache with light sensitivity, sound sensitivity. There is another headache called cluster headache, which can have similar symptoms, hemicrania continuous. So I think it's important to try and diagnose and work out exactly what's going on, and then try these drugs that we talked about. Worst case scenario, if none of these works, there is a drug called dihydroergotamine for migraine. It can be used for chronic cluster headache as well. So essentially, it's an infusion given in hospital over a period of 3 to 4 days. And again, that's a last resort. We ideally do not want to keep people in hospital for 3 to 4 days. It is a good drug, but it can have some side effects. So nausea is a very common side effect with that, and leg cramps. And again, if the patient has a history of heart disease, then it's a no, because it can potentially constrict the heart blood vessels. So that's a last resort available in hospitals, but you have to have tried all the others first before going to
and just going back to getting the right diagnosis for what type of migraine you have. Do you know of any research around people that having one type of chronic migraine having multiple migraine types or anything like that? Is there anything that you know on that topic?
Oh yeah, I mean, migraine can tend to cycle.
Mm-hmm.
You may have a patient may have episodic migraine, go on to chronic, and then go back to episodic. I mean, that thing can happen.
Mm-hmm.
Um, and again, I mean, migraine is 3 times more common in women compared to men. And in women, uh, there are several times that the migraines can shoot up. Like, for example, when women start their periods, potentially during pregnancy, and again the perimenopausal, so it can shoot up and then it comes down. So
Mm-hmm.
yeah, the headaches can cycle. The other thing is people may have more than one headache phenotype. uh, so say for example someone has cluster headache, they may also have migraine, and both of them may need to be treated separately because
Mm-hmm.
the drugs are different.
And how do you go about getting the correct slash diagnosis? Yeah, what would you suggest? What are your suggestions on that?
I mean, I guess because my interest is headache, I've got a structured way of asking questions about a
Mm-hmm.
headache. So I make sure, so I've got a checklist in my head, and
Yeah.
I make sure I ask all those questions.
Mm-hmm.
Uh, the problem of skipping the questions is that it's very easy to miss the diagnosis if you skip any of those questions.
Mm-hmm.
I've seen instances where people with cluster headache, they were diagnosed as migraine, or people with so subarachnoid hemorrhage. This is a condition where there's a catastrophic bleed in the head, but because all the questions were not asked, then it's been diagnosed as migraine. So I guess for me it's a question of having a structure and then making sure you ask all the questions before making that diagnosis. If you just ask 2 or 3 questions, like you have light sensitivity, sound sensitivity, nausea, if you just ask those questions, then you might miss the actual diagnosis. You need to know, like, how many days do you get the attacks, whereabouts on your head do you get the attacks, light sensitivity, sound sensitivity. If someone's headaches are waking them up from their sleep, it that that could be a warning. So there are certain things that are called red flag features in headache, and
Mm-hmm.
it's important that you ask about them and make sure that people don't have any of them.
Mm-hmm.
If people have one of these red flag features, for example, headaches that wake them up from their sleep, headaches that get worse when they cough, bend down, or sneeze,
Mm-hmm.
uh, new onset headaches after the age of 60, for example. If people have got a background history of cancer and then they start getting headaches,
Mm-hmm.
I think these are called red flags in headache,
Mm-hmm.
and all the people with that would need brain imaging.
Mm-hmm.
Uh, in migraine, usually we don't need brain imaging. If the history is typical for it and the examination is fine, we don't really need to do any brain scans.
I know there's a few people that have mentioned to me over the month that they do wake up with migraine attacks. So for those people that are watching this, perhaps it's best that you head back to your healthcare team and get something more looked at in regards to those things.
I
Yeah.
guess the scan is just for reassurance mostly.
Mm-hmm.
Uh, I mean, migraines may wake people up. There's another headache called hypnic headache that characteristically wakes them up at 2 o'clock or 3 o'clock in the morning, and gets better if they drink coffee at bedtime and then go to sleep. But if you get that history, I think it is important to do a brain scan and make sure that there's nothing worrying going on. Yeah.
Absolutely. Oh, I feel like we could spend all time talking, but I will wrap this up, as I know you have a lot of other things to do. But thank you, Pyari, for joining us on tonight, talking to us, and this will be up shortly for the world and Migraine New Zealand people to see. So thank you very much for joining us here tonight.
Thank you for the invite, Briar. Thank you. Bye.